and it's so important to standardize testing. It seems sort of an apparent contrast that we are using different definitions for study groups, which seems to be like cause convoluted, conclusion at most the wall. So there seems to be this dichotomy of, well, in one regard, we're standardizing everything, but then we're using different definitions. How can you reconcile that?
Yeah, I think that's a very good question, and it does sound confusing. I understand that. I think you need to understand that most papers will start out saying they use the 1994 case definition, and they don't explain how they used it. The one difference that we did was we explained how we used it in great detail. And I think that the 1994 case definition, and there was a meeting that a lot of people attended, that indicated there were a lot of ambiguities or a lot of different approaches that people could use to apply the 1994 case definition. And so what we did was come up with a very specific, I guess somewhat standardized instruments to measure each aspect of the 1994 case definition, and we spelled it out. Now, what we didn't do was get a lot of detailed explanation about how we came up with our cutoffs. We didn't provide that to the group, and that's what we need to do in the next paper, and then discuss, should we have used this cutoff versus that cutoff. And when you start using instruments to measure various things, when I say instruments, a lot of them are questionnaires. They've been used in a number of different studies. Then you can start saying, wow, if I use this cutoff, the population isn't the way that I would like it. You could shift the cutoff one way or the other. And it will allow, in the long run, for people to have more reproducible ways of grouping people with their illnesses. Now, people and illnesses, honestly try to defy classification. What I mean is there's a lot of fuzziness. And even in the same group of people, if you give the same questionnaires, a month later, the illness changes, people change, and nothing is going to be absolutely reproducible. And we do have to understand that, which is why I'm saying we need as many different dimensionalities as we can get. It's not so simple to say this person meets criteria, they're CFS. Clinically, it's a very different situation in that if you don't meet all aspects of the case definition on one day versus, the next time you come in, unless the illness is resolved, clinically they would be still managed as a CFS patient. So the main reason that we try to come up with a research case definition is, again, to try to assure that the findings are reproducible from one group to the other. And despite years of using the same case definition, the 1994 case definition, it hasn't been happening. And that's one of the things that has really blocked progress, in that one group finds one thing and the next group looks for it and doesn't find it. And don't believe that it's poor science. I believe it's differences in the patients that we're not fully accounting for. And that is, if we can solve that problem, and that's where, having dialogues and measures, and people look at their patients and realize that, there's got to be something explaining this problem. And those differences could also impact response to therapy and could become very good stratifiers for directing therapy as well. And that's what I hope will happen as we move forward.